Good afternoon, everyone. Thanks for coming to the Healthcare and Affordable Care Act Forum. This forum is sponsored by Wood County Indivisible, a local, nonpartisan, progressive organization. One of the core values of Wood County Indivisible is that affordable health care should be available for all Americans. The ACA was enacted in '09 and was fully implemented January 1st of 2014. Important goals of the ACA is to make affordable health care available to more people and to expand the Medicaid program to cover more lower-income groups. And I'd like to announce that today is the opening date for enrollment in the ACA for 2018. And before I forget, I want to announce also that there's going to be an open forum for enrollment in the ACA next Saturday, this coming Saturday, from 10 until 7 at the Judge Black Annex, which is right next to the old courthouse. And we'll announce that again, and there is some information about it as a handout. This forum is a nonpartisan look at the current state of the ACA and how recent efforts to weaken the ACA have affected it and have affected healthcare in general. We will also look at the insurance markets, the future of the ACA, and how to get assistance in selecting the best healthcare plan for you. I would like to introduce our panel in order of when they speak. Sarah Townsend has been in the field of human resources for many years and was an assistant director of personnel for the state of West Virginia, manager of performance development at Shell Kraton Chemicals, manager of human resource development at Borg Warner GE Plastics, business adjunct faculty for WVUP, Wheeling Jesuit, and Ohio Valley University, and president of Organizational Management Incorporated. She is a community advocate for mental health and a community health education resource person from the West Virginia School of Osteopathic Medicine. And thank you, Sarah, for being on our panel. Ms. Townsend will provide an overview of the Affordable Care Act since its inception. Second panelist is Julie Schleier, and she has studied the Affordable Care Act in depth. As a retired small business owner, she has been covered under the ACA since the beginning and has benefited from it greatly. Ms. Schleier has been a community activist and lobbyist in attempts to save the ACA from repeal and from being weakened. Ms. Schleier will address recent attempts by the administration to weaken the ACA. James Fawcett, our third speaker, has been president of Highmark Blue Cross Blue Shield West Virginia since October of 2016. Highmark is West Virginia's largest commercial health insurance carrier. Mr. Fawcett is responsible for all market functions for Highmark, which serves more than 275,000 members and 3,500 clients through the company's healthcare benefits business. With offices in Parkersburg, Charleston, and Wheeling, it employs nearly 700 people. Mr. Fawcett has been with Highmark for more than 29 years. Prior to becoming president, he served in a number of leadership roles. Mr. Fawcett will address the effect of the recent events on the insurance markets and insurance premiums. Speaker after that is Kelly Allen, who is the lead marketplace navigator for West Virginia Healthy Start Navigator Project, a nonprofit dedicated to helping West Virginia families look at their options for health coverage. A navigator is an individual or organization that's trained and able to help consumers, small businesses, and their employees as they look for health coverage options through the ACA marketplace, including completing eligibility and enrollment forms. Joining us by telephone is Catherine Stahl, who is a healthcare and ACA policy expert. She's a West Virginia resident and former deputy director of Families USA, a national healthcare consumer advocacy voice based in DC. She has a master's degree in economics and has been an attorney specializing in healthcare policy for over 30 years. Ms. Stahl will address the future of the ACA. I'd like to ask you to please hold your questions till the end, when we will have a question and answer session. Okay, our first speaker, Sarah Townsend. Again, Ms. Townsend will give us an overview of how the ACA changed things in healthcare coverage.
Thank you very much, Susan. Healthcare has been a discussion point for the past 10 years. Really 9 years we have been discussing healthcare, whether it's a right, a privilege, whether we should have the ACA, not have the ACA. And we've also really started to discuss what it meant when we didn't have protection in healthcare. So I'd like to talk about those 10 years ago, about how healthcare used to be. You may have had healthcare with your employer, and you helped in the cost of that healthcare coverage insurance by your deductibles, your co-pays, your co-insurance. But your employer could say, no, I'm not covering maternity care. Or could say, no, I'm not going to cover your Crohn's disease because that was a pre-existing condition before you joined our organization. So it wasn't always great, but it was good health insurance, and we liked it. If you were 65, you had Medicare. It was wonderful, except for those extra costs, but also that donut hole was very difficult when you started to pay for your prescription drugs. If you were disabled, you had SSI or Medicare disability. If you had a low income and a child, you were lucky because your child was going to be covered by the Children's Health Insurance Program, CHIP, but that didn't give you coverage. If you were employed, self-employed, owned your own business, you had to buy your own insurance. And you had to buy it on the individual small market, as I call it, small group. Your insurance may have just covered doctor's visits, or maybe your insurance, it was so much easier and cheaper for you to buy catastrophic and hope for the best. And maybe you just didn't have health insurance because you had a pre-existing condition and couldn't get it. Or you couldn't afford the insurance no matter what because you were too old. You were in that 50 to 64-year-old market and probably had a pre-existing condition. Or you were healthy and you didn't want to pay for it. And you really thought, that's okay, because nothing will happen to me. But you could have been that person that had to declare medical bankruptcy because of a cancer diagnosis and cancer treatment, and you lost everything. Then along came the enactment of the ACA. And it was to be fully implemented in 2014. Things did change. The first thing we saw was all these kids that were on their parents' insurance because they could. As long as they were under 26, they could stay on their parents' insurance, and a lot of parents did that for their kids. If you were an individual and made less than 138% of the federal poverty level, or $16,642, or as a family of four, $33,948, and you lived in a state like West Virginia that expanded Medicaid, you would have health care coverage. Maybe for the first time in your life, you were working and had health care coverage finally. You could no longer be denied health care because you had a pre-existing condition. And those annual and lifetime limits were eliminated, which meant you didn't need to declare bankruptcy when you had that cancer diagnosis. The insurance companies were required to spend 80% of their income on health care coverage. That was one of the things that they added. Required insurance plans had to provide what we call the 10 essential benefits. And probably the 10 essential benefits has really made people stop and think and say, oh, you mean I get it now? Or I didn't know I didn't have it? But that was really something that was really important. So now outpatient care was covered for everyone who had insurance. Hospitalization, emergency services, that maternity care, those preemies at $1 million, that was covered. Mental health and drug addiction treatment was covered. And that's one of the things that I've talked about so much. In our opiate crisis that we're having, part of the problem was people who didn't have health insurance, and they didn't have a way to receive mental health treatment or substance abuse treatment. Now with the ACA, they could. Rehabilitative services, prescription drugs, laboratory services, preventative services, and pediatric services were all part of the 10 essential benefits. Also, now there were some services that were preventative that were free, like that annual wellness visit. Tax credits were provided to reduce the cost of premiums of customers with incomes between 100% and 400% of the federal poverty level. So there were tax credits available for premiums. In order to make the selection of insurance, because now we were really choosing insurance ourselves for the first time, there was a way to explain what insurance was, so you were comparing apples to apples, not apples to oranges. So they made the levels of insurance. And it's really how much you paid versus the insurance company for your health care costs. So a bronze plan was 60%, the insurance company paid. If you were in a silver plan, it was 70%. Gold was 80% that they paid, and those few people that wanted a platinum plan, it was 90%. But that meant your premiums went up for every level. But it was a help in the selection. And the one thing that happened is premium costs were no longer based upon your gender, because women did pay more before. And it was no longer based upon your health status. However, it was based upon your age, because they could now, but only charge 3 times more than a younger person. So there were some things there that helped. But it did make the premium market and the insurance market, as I call, more rational and logical to understand, to make selection. It also said, hey, employers, if you have more than 50 people, you need to provide insurance for your people. It provided a cost-sharing reduction subsidy to the insurance company, which enabled the insurance companies to lower your out-of-pocket costs, those deductibles, the co-insurance, and the co-pays. It helped fill the donut hole. Okay. It did provide a small tax cut for small businesses. It did charge a penalty if you didn't sign up for health insurance. There was a penalty. You know, those young people didn't think they needed it. They got a penalty. There was a tax imposed to help pay for this on incomes over $200,000, and a small tax on some small businesses. It also implemented regulations on hospitals, drug companies, and insurance companies to reduce costs. So part of the ACA was reducing costs. I'm going to ask you a question.
What happened? What were the outcomes of the Affordable Care Act?
Well, I think people care about it now. I mean, I think this is our 14th or 15th event that we've had, and people are coming to, because they are really realizing what would happen if they did lose the ACA. But one thing, 20 million more people have health insurance than had before.
That's really impressive.
Right. Okay. 8.7 million people are helped by the marketplace tax credit, and 5.8 million people are helped by the subsidies. In the average premium subsidy in 2017 was $4,452. This is how many facts can I get in the shortest amount of time. But there are a lot of things that happen. One of the things that happened was the medical bankruptcies that happened from 2010 to 2015 were reduced by 50%. Think about that. Those people didn't have to declare bankruptcy. It did increase jobs throughout the nation, but in West Virginia, 16,000 healthcare jobs were created because of the Affordable Care Act. Now, seniors on Medicare are seniors. We saved more. 8.2 million seniors saved more than $11.5 billion in prescription costs. That's a big deal. There was also a reduction in the projection of increased healthcare spending. That helps too. The uninsured rate now is 10.3%. Hospitals' uncompensated rate were estimated to be reduced by $7.4 billion in 2014. Because remember, you were told to go to the emergency room if you were sick? And you didn't have insurance, so everything, you just go to the emergency room and they'll take care of you. Well, that sure ran up the prices a lot, and then the hospitals didn't get that money back. So this has helped the hospitals. The ACA has been wonderful if you were sick and poor. There's no doubt about it. It's been great. Where it's been a problem is for the individuals who are struggling to pay those premiums that don't get cost subsidies or they don't get a tax cut, a tax credit. You have to understand the market that we're talking about is a small part of the market. If you have 300 million people in the United States, 155 million receive their insurance from employers. 43 million receive it from Medicare. 62 million receive it from Medicaid and CHIP. 6.4 million receive it from veterans or TRICARE military. There's 29 million uninsured. So what's left is about 21 million people that are having difficulty with the ACA on the cost of the premiums. So there's been overall satisfaction because they haven't been able to repeal it 60 times they've tried, because people do see that the patient protections are really valuable. But we do need to look at that individual market, which is 7%, and determine how we can strengthen the ACA and improve it.
Thank you, Sarah. Our next speaker, Julie Slyer, will discuss the attempts to repeal and sabotage the Affordable Care Act since January of this year. We're all familiar with some of the executive orders that were enacted about the Affordable Care Act, but before you get into those, what are some of the threats and actions that have occurred in addition to the executive orders?
Okay, threats and actions that have caused uncertainty in the marketplace. For months, the administration has threatened to withhold or stop the cost-sharing reductions. The administration also threatened to change Medicaid to a waiver system which would make it harder for Medicaid beneficiaries to get care. They have shortened the annual enrollment period from 90 days to 45 days. They cut it in half. Congress tried unsuccessfully over 60 times to repeal the ACA, causing uncertainty about the future of the program. All this has caused so much uncertainty about the ACA that in June, Anthem pulled out of the market, causing uncertainty as a reason, and they were worried about whether the cost-sharing reductions would be paid. Other insurance companies have followed suit. In July, and there's been other attacks that have attacked, other actions that they've taken attacking the ACA. In July, the Department of Health and Human Services released 23 videos explaining how the ACA harmed people. They had individuals up there telling their story of how they were harmed by the ACA. 23 videos. The administration ended contracts with 2 private firms to provide in-person assistance in states using healthcare.gov. In August, it was announced that funding had been slashed for marketplace outreach by 90%, navigator programs by 40%. In September, it was announced that applications wouldn't be able to be completed on Sunday morning during the shortened enrollment period, Sunday morning being the very popular time where people would sign up at community events and faith-based gatherings. HHS has stopped its staff from participating in marketplace enrollment events. And in October, the administration announced that it's allowing employers to opt out of covering contraception based on a moral or religious objection.
What are the President's executive orders, and what were the effects of the executive orders on the Affordable Care Act?
Well, on January 20th, his first day in office, he signed an executive order that directed federal agencies to use their administrative powers to begin dismantling the ACA to the maximum extent permitted by law. The order instructed agencies to do what they could to delay implementation of the ACA provisions that imposed a tax fee or other costs, and to encourage development of a free and open market in healthcare services among states while Congress worked to pass repeal legislation. Fortunately, to date, repeal legislation has failed. In October, he had the October 12th executive order. It directed agencies to consider ways for more people to buy health care coverage that's exempt from many of the standards of the ACA. This included the junk policies, such as short-term substandard health insurance plans and the association health plans. These policies would be exempt from the requirement that health plans cover a package of the 10 essential benefits, including maternity care, mental health treatment, and prohibition against charging people different premiums based on their health status. The October 16th executive order, the administration announced that it stopped making cost-sharing reduction payments to insurers, which helped lower deductibles and other out-of-pocket payments for roughly 6 million low-income and moderate-income people. This action will raise costs for consumers and further disrupt the health insurance markets. The Congressional Budget Office has estimated that ending those payments will raise the number of insured people by 1 million in 2018, increase marketplace premiums by 20%, and cause insurers to pull out of the marketplace, leaving some consumers with no marketplace plans. And far from saving the federal government money, ending those cost-sharing payments will increase the deficit by $194 billion over the next 10 years.
The recent budget resolutions that were passed by the House and the Senate have cut funding for many, many programs. What would the effect of the budget resolution be on health care?
Under this proposal, the health care programs would be particularly affected. All Medicaid programs would see a cut of $1.3 trillion, or nearly 30% by 2027. Medicare would be cut too, to the tune of $473 billion. Funding for non-Medicare health programs, most notably Medicaid and the ACA, would take a $1.3 trillion hit, 20% cut over the course of 10 years, increasing to a 29.3% cut by 2027. By cutting Medicaid, it would greatly affect 16,000 jobs in West Virginia. 75% of patients in nursing homes are on Medicaid here in West Virginia. If this cut is cut, be prepared to have grandma come to your house. We would also lose more jobs. With no additional federal CHIP funding, states would start exhausting their remaining CHIP funds. Utah, for example, which expects to run out of federal CHIP funds at the end of December, is preparing notices to send to families beginning November 1st that the program is at risk of closure. Altogether, a Kaiser Family Foundation survey found that 11 states expect to run out of their federal funds by the end of this year, with the remaining states expected to exhaust their CHIP funds sometime in 2018. As a result, states with separate CHIP programs, in which about 44% of children with CHIP coverage nationwide are enrolled, may be forced to cap or freeze enrollment or shut down their programs entirely. States with CHIP-funded Medicaid expansion must continue coverage for their CHIP-eligible children, but at the state's regular Medicaid matching rate, which is well below the CHIP matching rate.
Could you explain the change in the re-enrollment for the ACA?
For a person who's enrolled in the ACA for 2017, if no change is made in the enrollment during open season, the person will be automatically re-enrolled in the same plan as they were previously. A letter announcing that re-enrollment is sent on or around December 15th. In previous years, this gave a person enough time, about 45 days, to make a change in their plan after being automatically re-enrolled. This year, however, they shortened the enrollment period, but they did not change the date of the letter. So people will be receiving those letters right as the enrollment period is ending. Automatic enrollment is a good fallback, but the best way to make sure you have a 2018 plan that works for you with the savings you qualify for is to log in as soon as today, November 1st. Update your application, view all your plan options for 2018.
Second.
Thank you, Julie. Our next speaker, Jim Fawcett, will share with us the effects of recent attempts to weaken the ACA on insurance markets and what the insurance markets or the insurance companies are doing in response.
Thank you. I'm Jim Fawcett with Highmark Blue Cross Blue Shield, West Virginia. I've lived here now for about 13 months, still learning where everything is. First time I've been in this room. And I have brought one of my fellow coworkers with me today because today being November 1, open enrollment date, been on 2 radio shows, I've been interviewed by a couple newspapers, and one of our employees' 93-year-old father called and yelled at her because her boss was raising his Medicare rates by 25%. So first thing I want to say is, transparency of communicating today, everything I'm going to talk about does not impact Medicare or Medicare Advantage. However, it is open enrollment season. Open enrollment's October 15 through December 7. And we did bring a Medicare Advantage, a Highmark Medicare Advantage expert with us. So Stephanie, if you could raise your hand, because I am not one. I rely on our team all the time. And also, I'm going to be talking, you'll see me every now and then referencing a brochure. This is our 2018 brochure. The PDF is on our website. Just go to highmarkbcbswv.com. Say you want to find insurance and everything. All of our products, our rates, everything's in here. But to talk globally about how this has impacted us, Highmark, West Virginia, we've been in all 55 counties since 2014. Why is that important? Because the key benefit for individuals is if they can get a product in their county that's made available to them, that's how they get access to the subsidies. One of the subsidies, I'm not going to go into great detail today, is the annual premium tax credit, APTC, but that's the pure premium credit. And 87% of our customers, Highmark, Blue Cross Blue Shield, individual customers, get that subsidy, and the average value of that is $350 a month. So that is incredibly important. So as we talked about other carriers making business decisions to exit markets, exit counties, exit states, whatever that is, we know the importance of us making our products available because that's how you get the subsidy. So the good news is if you're one of our customers today, or hopefully if you're thinking about buying us, we would like to sell to you. We're in all 55 counties. We have catastrophic bronze, silver, and gold programs available in all counties. If you're one of our existing members, basically very little's changed. So the same programs are out there, the same products. I want to talk about the rate of increase because it is substantial this year. Our approved rate increase from the West Virginia Insurance Commission is 25.6%. I'll be candid, we filed for higher than that. 3 buckets of increases in there. The first bucket of increases is the normal inflationary trend that happens in health insurance. The cost of drugs, new technology that comes out, people getting, I would always say that we spend more money on failing to walk, proper diet, and managing our stress, because when you look at the impact of diabetes, hypertension, and depression, all of that's controllable. And I never want to lose fact that we can still impact by doing more exercise, diet, and managing stress. So that's one bucket. The other bucket that's really challenging in individual markets is high-risk members. Less than 5% of our members, and we have roughly 30,000 individuals that buy individual policies, and that's less than 10% of our total book. But less than 5% of those people account for over 50% of the total expenditures. These people are very sick, very vulnerable, very complicated, who we need to have coverage with. And what's a little unusual about this market is that full cost is spread on this population. There are some efforts nationally, I think Alaska's been a leader in this, of trying to do something to fund those extremely high individuals in a different way. And there's a lot of ways we can do that. But in our rates, we're bearing the weight of that 5% of very complicated people in our rates. And I am going to quote, because our insurance commissioner has made it public, this is public knowledge, that the other component we did was uncertainty about the future. And we had 2 areas that we were very specific in our filing. We were very uncertain, in fact, darn right, smart, that the federal government was not going to fund the CSRs, the cost sharing reduction. And that's, I'm going to get into real detail now, but the other part that we're very concerned about is individual participation. Whether you call it the individual mandate, however you do it, we're very fearful whether it's enrollment activities or other things that could happen. If we don't keep the younger and healthier people in those risk pools, this will not be viable long-term. So when we did our filings, and I am going to get into the cost sharing reduction, roughly our increase would have been 14%, but it's 25% because we anticipated not being paid by the CSR and were concerned over the individual mandate. I'm going to back up a second. You could push back and say, well, because we did these filings last spring, how could you take that position? I have to go back to 2014 because we've been in it in the beginning. There was originally something called the 3 Rs. There was risk adjusters, risk corridors, and reinsurance. And it was in all industries saying, hey, this is a new, potentially volatile market. There were things in the law that kind of said, hey, insurance companies come in, we understand you're going to have a rough couple years, but we'll stabilize this. And we, and my company, and I have to go up a higher level, Highmark Inc. is a Blue Cross Blue Shield plan in Pennsylvania, Delaware, and West Virginia. We're one of the 3. I'm the market president for West Virginia. In all 3 states, our company lost almost $1 billion since 2014, of which more than half of that should have been covered by the CSRs. So we're a company that has learned firsthand that even though it was in the law, it might not get paid. So when we took the position that, well, we're hearing in the marketplace that CSR may not be paid, we put it in our rates. So it's a good news, bad news. The good news is if you're one of our customers, we have all the products out there. If you're eligible for CSR, which I'll get into, you're gonna have it. The bad news is if you're one of our 10% of customers that pays the full premium out of your own pocket, that rate that should have gone up more like 14%, it went up 25%. So that's where that went in. I do want to talk about cost sharing reduction. It's often called the insurance company bailout subsidy, et cetera. I want to talk about how it really works. So there's a, let me grab this plan here. One of our programs, a silver plan, which would be the typical plan that one of our members would buy, 87% would get the premium subsidy. Roughly 50% of those people would get the cost sharing reduction eligibility. And I hate to get so technical, but it's important that you understand how it works. It's income based, and there's 3 levels of reduction subsidy that you're eligible for. So I'm going to use an example of one of our customers who bought a silver plan and ended up in the most highly subsidized area between 100 to 150% of FPL. Here's the numbers. If you bought our silver plan, we have a couple of them, but I'm picking this one because it's so dramatic. The deductible that was necessary to hit the 70% actual value you talked about was $5,700. So if somebody got sick, was in an accident, before we paid any benefits, you had to pay $5,700. So credit card, cash savings, family, church, whatever it is, there's a lot of ways to do that. So the premium set for that plan was based on a $5,700 deductible, so that's going to lower the premium a little bit because we don't even pay anything until $5,700. There's a few exceptions for wellness, et cetera. If you qualified for CSR, you would have paid the same premium as the $5,700, but your actual deductible for this plan was $200. That's substantial. And here's what I liked about CSR. So instead of us doing what we did, which is spreading the cost among everyone, the way CSR actually worked is every quarter, when we should have taken a $5,700 deductible but only took $200, that $5,500, only when one of our members actually incurred those costs did we bill the federal government. So it wasn't, it was only when used. There was no actual estimation where we fudged it up a little bit. It was based on it. So the nice thing about it was if you used it, we billed the federal government. We were made whole because that's how we priced our product. And the federal government only paid for it when one of our consumers used it. I always thought that was pretty fair. Have no idea how that became an insurance company bailout. It's not, and it's incredibly important. So as we look forward, I won't even venture a guess for 2019, but we're a company in West Virginia that's lost nearly $100 million. We have over 750 West Virginia jobs. You know, my goal is to grow the company. I'm going to be very candid. We can't bankrupt our company over the individual market. I'll be candid, I thought we were leveling off this year. I thought this would have been that year that we kind of would have stable We could argue whether a 14% increase was real or not, but unfortunately, that's kind of the way healthcare goes. But hopefully, I've made it a little more clear of how cost sharing works and how important it is for our covered members. Does that help?
That's great.
Complex, but
That's incredibly helpful. All right, next we have Kelly Allen, and she'll explain what a navigator is and what they can do to help an individual select the best plan within the Affordable Care Act in the individual market.
Okay, so thank you. I'm Kelly, like she said, and I work with the West Virginia Healthy Start Navigator Project. We are out of West Virginia University, and navigators were built into the Affordable Care Act. We're part of the law. They're required to be people on the ground in every state, just knowing, when everybody talks, this is a really complicated process. There's a lot of political rhetoric floating around, so we kind of have three primary duties year-round that I think of. We do outreach, so we tell people like, hey, the ACA still exists, and we do that all year round. We try to do a lot of education with helping people know what's covered in their preventive services, know where to find a doctor, know when it's appropriate to go to the emergency room and when it's better to go to a family doctor. So these are kind of maybe the long-term things that are going to help, well, before this year, that we may have thought would help stabilize the marketplaces a little bit better. And then the third thing we do, and what we're really doing right now during the enrollment season, is actually meeting with people one-on-one and helping them enroll in coverage. So we help people with anything related to the ACA. So we do Medicaid applications, we do CHIP applications, the Children's Health Insurance Program, and then the bulk of what we do is the marketplace applications. So we'll meet with people, kind of talk them through what they qualify for, help them do that application, help them estimate their income. That can be really complicated for people in the individual market if they're self-employed or working part-time, or their income kind of fluctuates. So we do a lot with that. And then actually helping people select the plan that's going to be the best for them. We kind of get into the weeds of chronic health conditions and medications and prescriptions and physicians, and kind of help them figure out what's going to be the best for them. So that's pretty much what we do. We cover the northern 29 counties, so north central West Virginia and both panhandles. There's another navigator grantee that covers the rest of the state, so we are in every county. We can help anybody in the state.
Thank you.
Did you have any more questions? I have a lot of points that I want to make, if that's
please.
okay.
How can you help with the intricacies of the ACA plan?
Your mic is.
Oh, yeah.
Oh, sorry.
Why don't you repeat the question?
I can repeat it. Yeah, she just had asked about the intricacies of the marketplace plan. So all of our staff went to a training earlier in October that the Insurance Commission put on, where we kind of got training on Highmark's plans and then Care Sources plans, which is the other company in 30-ish counties in West Virginia. So, and like I said, we try to really learn a lot about the person's financial situation, about their health situation, just kind of make sure that we're making sure that their physicians are in network with whatever plan they select, and talk to them about affordability and make sure that it's something that they're going to actually be able to use.
What kind of paperwork do people need to bring with them when they enroll?
The most important things that people need to have are social security numbers and birth dates for everybody in the household, something that's going to help us estimate their income for the same year or the next year that they're buying coverage for. So if that's tax returns or pay stubs, if you have an email address, you should bring that with you and make sure you can check it. But really it's just kind of household and income documentation that will help us. And if you're offered coverage through your job, typically you're not going to be offered subsidies on the marketplace, but that's something we can help people figure out too. If they know how much their coverage costs through their job, and we can help them find out if it meets minimum value requirements and if it's affordable.
And please share with us any other
Okay.
bits of wisdom that you have as a navigator.
So I really think it's really important to strike the balance between, as advocates for the Affordable Care Act and activists in the room, that we should be pretty hair on fire about what's going on with the administration and Congress and efforts to undermine the Affordable Care Act. But on the other hand, I think it's really important for people that need insurance or who have marketplace coverage right now to know that for most of them, absolutely nothing is changing in 2018. Cost sharing reductions, although they're not being reimbursed by the federal government, the insurers are still required to offer them. Premium tax credits are still going to be offered. I'm getting calls from people that think that subsidies have gone away, that think that the ACA has been repealed. So it's really important that if you're in that 85 to 87% of West Virginians who qualify for financial help, and I mean, that's a pretty substantial amount of people. A single person can make about $48,000 a year and qualify for these subsidies. A family of four, about $98,000 a year. So it's really, you know, a big percentage of West Virginians. So anybody that's in that group that qualifies for financial help, as premiums go up every year, the subsidies go up too to keep your coverage within an affordable percentage. So if premiums go up and your income stays the same, you know, your subsidies are just going to lift up to match and make sure that the plan is still affordable for you. So I think that's really important for people to know. We already highlighted that today is the opening of open enrollment, but it ends on December 15th. And I would advise that nobody wait until December 15th to sign up. I've experienced a lot of crashed websites and jammed phone lines in my day. And in past years, the Obama administration has extended the deadline a few days for people that couldn't get through. We don't know if that's going to happen this year. So I definitely sign up sooner than later. And I did want to also mention that the IRS did announce last week that they are going to enforce the penalty in the spring when people are filing their 2017 taxes for people who are uninsured. So there have been some waffling on that, but the latest information that we have is the Affordable Care Act is still the law. There is still an individual mandate, and people will still be penalized if they go without coverage. And also, just to add something to that, another thing that we do is we do help people file exemptions for the penalty. So if you truly cannot afford to have health coverage, we can help you see if you qualify for an exemption. If you have issues with the marketplace, we can help people do appeals. So we try to be really full service and be helpful to people year round. And then I think that's really it. Did you have any other questions?
I don't have any other questions.
Okay, cool.
Thank you very much. That's a lot of help. I think, you know, when you read about all the different plans that there are and all the different, you know, benefits, I think it would be essential to have a navigator to help. And I know I mentioned it before, but I'll mention it again. There's going to be an enrollment session on Saturday, this coming Saturday, at the Judge Black Annex, which is just next to the old courthouse, from 10 until 7 p.m. So pass the word, you know, spread it around to your friends and neighbors or people who may want to take advantage of that, because that could be really helpful. Okay, next we have Catherine Stahl. She's here by telephone. I have her nameplate, and I'm holding it up. So anyway, she's here by phone, and we're going to ask her to wrap up the program and talk about the future of the Affordable Care Act. Catherine?
Okay, thank you. Can you hear me?
Yes, we can.
Okay, you can hear me? Well, first of all, I just wanted to make sure that, Kelly, I couldn't hear you too well, that you shared the 1-800 number.
I did not.
I'm getting an echo. I'm sorry about that. I hope you all can't hear it. The 1-800 number is 1-800-318-2596. So if you're not into using a computer and going to healthcare.gov, that's another way that you can find out about your options. I still have that echo. I hope you all don't have it.
But you're coming in just fine.
Repeat the number.
We need her to repeat the toll-free number.
Yeah.
I can do it.
Kelly's gonna.
Yeah. So the Marketplace Call Center is 1-800-318-2596.
Right. 1-800-318-2596. And Kelly, also, I guess I'm actually asking you questions as part of the wrap-up. The open enrollment period is tighter this year from November 1st to December 15th, but people can also sign up for the marketplace plans during special enrollment exceptions. And I think some of those are divorce, for example, or losing your job. And you might want to mention a few of those for folks.
Yeah, do you want me to do that right now?
Go right ahead.
Okay, yeah, so outside of regular enrollment, or open enrollment is the time when anyone who doesn't have coverage can join the marketplace for 2018. But generally people who lose coverage mid-year are going to be eligible for a special enrollment period. And they have to sign up within 60 days. So that loss of coverage could be tied to a divorce, losing a job, as Kat said, also marriage. As long as one person already had coverage can qualify you to get a special enrollment period, the birth of a child, moving to a new state. So really, that's something that somebody can contact a navigator or somebody to clarify that. But it's really important to do it within 60 days of any qualifying life events.
Thank you.
Thank you, Kelly. The other thing is that if you think you may be eligible for Medicaid or your children for the Children's Health Insurance Program, CHIP, there's no open enrollment period per se. You can apply and be accepted into those programs anytime during the year. It's only for the marketplace and those important premium tax credits and cost-sharing reduction subsidies that others described that have this limited open enrollment period. I just want to make those points. Then turning to the future of the Affordable Care Act, it's in the hands of Congress and the President. That goes without saying. Again, it's alive and well right now. We fought back attacks on the Affordable Care Act over the course of the summer. Others have mentioned that. But we fought those back. The process of democracy worked. The fight is not over, however, and as one of the speakers mentioned, the tax cuts that are now being considered in Congress in the context of the federal budget, which are likely to be put into place, will reduce revenues for the federal government, and whether you like the tax cuts or not. I personally think they're targeting the wealthiest people and will not benefit if anyone in the middle class. But when you reduce revenue, you increase the deficit, and a $1.5 trillion deficit will be of concern next year. It's not right now. They want to pass a package of tax cuts. And we will see that deficit become the reason to cut spending, and one of the targets for those spending cuts will certainly be the Medicaid program. It will be in the bullseye. So the future of the ACA is in part the future of the Medicaid program and the Medicaid expansion. In West Virginia, Medicaid covers about 650,000 of us. That's about a third of us. And I should also mention Medicare may be on the chopping block in Congress, and that covers about a quarter of us, or 420,000, and some people get both. So if you want to talk about the future of the ACA, you first have to say to Congress, do no harm to the Medicaid program. And the Medicaid expansion that was in the ACA covered about 220,000 West Virginians. And what I want to point out is that every effort to repeal the Affordable Care Act that we fought back and stopped over the course of this long year included significant cuts to the Medicaid program and significant changes in the way Medicaid is financed. And those changes would have even cut the Medicaid program as it existed before the ACA. So it wasn't just the Medicaid expansion on the chopping block, but the entire Medicaid program. And I think we'll continue to have that fight over the course of 2018. And let me be clear that if federal funding for the Medicaid program is cut, people will lose coverage. It's actually a very efficient program, and there's no magic bullets. We will see people and benefits and provider reimbursement cut if the federal partnership, the federal dollars that come to West Virginia are cut. If you want to talk about the future of the Affordable Care Act, you also have to say, and other speakers have talked about this, do no harm. Not only not do no harm to Medicaid, but do no harm to the ACA marketplaces. And as you have heard, Congress and our president have been on a path that has destabilized the market and forced insurers to raise premiums. We have about 37,000 West Virginians who get their coverage through the marketplace. About 85% of those get the premium tax credits. So what should Congress do? They have the opportunity to undo the executive orders that have already been described. they can fund robust enrollment efforts and not cut funding for marketing and education about the Affordable Care Act. Congress could also act to overturn the executive orders that reduce consumer protections in the marketplace. I won't get into the details of those. I'm glad to cover them if folks have questions, but basically they weaken not only the essential health benefits requirements, but allow some plans to be created outside of the marketplace that do not have the same protections for people with pre-existing conditions. You've heard a lot about the cost-sharing reductions. Congress can fund the cost-sharing reductions. And again, as Jim pointed out, this isn't about paying money to insurance companies. This is about reimbursing insurance companies for the help they provide to low-income people, help with deductibles and co-pays. And insurance companies have to keep providing that help. And so if they're not getting reimbursed, as Jim explained, we're going to see premiums go up. Congress can undo that. And in fact, there's a bill that's bipartisan in the Senate. Senators Alexander and Murray have a bill that would fund the cost-sharing reduction subsidies. That bill right now is stagnant. It's not moving. But it could. I could get into some more details about that. And I also want to point out that we expect to see, and have seen in the past, attacks on the premium subsidy structure. So right now, premium subsidies, or the premium tax credits, actually protect people from spending more than a certain % of their income on a benchmark silver plan. So if the premiums go up, and as Jim was describing, there are some reasons driving those up, people who get the premium tax credit are to a great extent protected or insulated from those premium increases. But the government, the federal government, has to spend more money on the premium tax credit. So people are still protected if they're eligible for the premium tax credit. For those of us who are middle-aged and middle class and maybe aren't eligible, we're getting hit hard. So Congress should not change the way those premium tax credits work, and that has been a proposal in the past, and we expect to see it in the future. That change in structure would mean when premiums go up, everyone gets hit in the pocketbook. And then I just want to touch on, and perhaps this makes me seem Pollyanna, that Congress could actually not only not do harm to Medicaid in the marketplaces, but they could actually improve them. And it is my hope that the Affordable Care Act, which provides help to so many West Virginians, could actually be improved. That Congress could actually move beyond this repeal and replace mantra and these attacks on Medicaid, and start thinking about how to improve the foundation of the Affordable Care Act. The Affordable Care Act reduced the uninsured rate in West Virginia from 20% to 6%. And I'd like to see us start attacking the 6% uninsured rather than the law that made the difference. Some of the things that Congress could do if they wanted to actually move forward, and of course, if the composition of Congress changes, that becomes a possibility. Congress could fund reinsurance programs, and I think Jim touched on this a little bit, but basically those programs help lower premiums by helping insurers who are willing to cover those of us who are the sickest, who have the highest cost claims. And that partial reimbursement allows insurers to hold down premiums for all of us. So reinsurance programs could be funded. And it actually, in the context of the federal budget, doesn't take a huge amount of money. Congress could fix the so-called marriage glitch. Basically, if you're married and you have an employer-based coverage, you're not eligible for the marketplace plans and subsidies unless you have to spend more than a certain part of your income on that coverage. The way it works now, they look at the individual and not at the cost of family coverage. So it's a mistaken drafting of the Affordable Care Act that normally would get fixed in a bipartisan manner after a law is passed. It's a technical fix. It's a language, it's a comma in the wrong place. We can't get it fixed right now, but it could be fixed. And the last thing is that we could increase the options available to people in the ACA marketplaces. First, if we quit creating this climate of instability and unpredictability, more insurers are going to be willing to offer plans, and they're going to stop having to raise premiums as much. But we can also create other options, particularly in places where there's 2 or less insurance companies offering plans in a state marketplace. And there's a couple things people talk about. They have merit. They need to be considered further. One would be to allow people to buy into the Federal Employees Health Benefit Program. Another would be to allow people to buy into the Medicaid program in a state who are above the Medicaid normal eligibility levels. And the third would be to create a new sort of public option, it's often called that, some sort of federal option that is available in all states. These are all ideas that would create new options in the ACA marketplace. We can't get to the point where we can even talk about them because we have been in such a defensive mode. The bottom line, though, is I believe democracy works, and I believe that we will preserve the ACA, and we will eventually get to a point where we can start to improve it. And my hope is that we'll start improving it for those who are above that magic 400% of poverty, the middle class who don't get premium tax credits, and who are facing incredible burdens buying health insurance for their families. And I think we can get there, but it is a political fight. It has implications for elections and the composition of the U.S. Congress. But again, when we hear about the things President Trump is doing to destabilize the marketplace, and some people use the word sabotage, Congress can reverse any of those executive orders.
Thank you very much, Kat. Is there anything else? Is there anything you would like to add to anything that the other speakers have addressed?
I think the executive orders were covered fairly well, but again, what is confusing about insurance, and I think Jim could explain this probably better than I, that is that you don't always want people to have too much choice in insurance. And I'm not talking about a woman's choice, but if you can offer a plan that has not all of the benefits, the essential health benefits, protections that we have now under the ACA, you actually peel off younger, healthier people. And they may, in fact, get a cheaper plan that serves their needs. But the rest of us are impacted by that division of the risk pool. So in some ways, we want to all be in this game together and all have essential health benefits covered in our plans. And when we do need them, because we all get older and we all get sicker, they're there for us. So some of this debate about offering very bare bones, skimpy plans through various mechanisms like short-term policies actually hurt most of us. And I would also put in a word of warning to the young and healthy folks in the room who think a very cheap bare bones plan off the marketplace looks attractive. Be careful, because any of us can end up in a hospital. My Halloween costume for this year was a hospital bill. You can imagine the cast, the crutches, the arm in a sling, and the Band-Aids on my head. But the point is, I was a medical bill, and that just to put my head on the pillow in a hospital costs an average of over $1,000 a day. And if you add in a doctor, medical treatment, anesthesia, surgery, etc., you're easily talking hundreds of thousands of dollars. And that's why insurance is important. And that's why good insurance that covers what you need when you need it is important.
Thank you again. Do any of our panelists have anything to add to anything that anybody said? Okay, great. Before we open for questions, I just want to remind you all again that there's an open season Saturday for the Affordable Care, for signing up for the Affordable Care Act. And to add to what Catherine said about influencing Congress, Laura has handed out cards, and on those cards are phone numbers for our representatives in Congress. So if anything said here tonight has made you think that you might want to contact your congressional representative and request that they fund Medicaid or pay the CSRs or improve the Affordable Care Act, feel free to use those numbers on your cards. Okay, now I'll open the floor to questions. Okay. I saw you first, so.
Hi, my name is Carmela, and we're going to be entering the marketplace for the very first time. I'm retiring. My last day is November 22nd.
Congratulations.
Thank you very much, I think. So, my question is, with what's going on with our health, does anybody ever get refused when you make application?
No.
Okay. And do you guys offer a dental and vision program?
Individual markets, no, we don't.
There are, the marketplace will offer you an option to purchase a dental plan from a separate company after you enroll in health coverage.
Okay.
And are no health questions on the application. There's no
No physicals,
approval
no jumping
process.
through hoops, no, we can walk in on our crutches and
Yeah.
wheel in and we're good.
Literally, the only thing they can ask you that's even like a tinge related is tobacco use.
Thank you.
Thank you.
Check us out, by the way. It is my job, you know. Please check us out.
That's one of the benefits of being on a panel.
Oh, and you, since you have a special enrollment period, I'm sorry, you will need proof that your other coverage is ending as like an additional document to have when you do sign up.
Okay, our next question.
Hi, my name is Karen, and my question has to do with when married couple, husband and wife, both have employers where they're insured, okay? One may have Blue Cross Blue Shield that has a high deductible. The other spouse has an insurance that has a more doable deductible, okay? Can the person that has the higher deductible, can they also be enrolled under their spouse's insurance and use that as like a supplement to pick up what that deductible doesn't initially?
As simple as your question is, it can be exceedingly difficult. It sounds like two employee people, correct?
Two people are
Yeah.
married, they're both insured,
Insured individual? or
but different
insured-
employers.
Yeah, so typically, there's coordination of benefit language that each of those employers will have. And the general, you have to read both, because there can be tricky language, and the self-funded plans can be different from insured.
Okay.
But generally speaking, the one spouse will be primary on theirs,
Right.
and the other spouse will be primary. The only caution I have is there are some federally qualified, like high deductible health plans. If you have like a health savings account, you need to be very careful, because that secondary coverage could harm your eligibility if you're in a qualified health savings account. Otherwise, theoretically, what you said probably makes sense. You got to read your two plans to make sure it's the case.
And that was my next question, the health savings account.
Mhm.
Okay, if husband and wife are married, okay, a husband and wife, they're married, okay. And they both work at different employers.
And we cover husbands, and wives.
Yeah,
first, too.
okay, yeah,
So
okay.
that's
But, health savings account, okay, and can one opt in to another's health savings account? Is that also
Both have to-
contract language?
It's- Well, if you're truly talking about a qualified health savings account, you both have to have the coverage of a qualified high deductible health plan. So whether you both individually have qualified high deductible health plans, this is primarily group talk, but there's a little individual in here. But you just have to make sure one of them doesn't have a non-qualified plan, because that's when you can jeopardize your health savings account. So whether you're both covered under one or both individually covered on your own, you can do that. And there's some limited health savings accounts too if you have vision and dental plans. But generally speaking, you can do that, but you've got to read your two policies.
Okay. And this ties in with it, so I'm sorry. somebody
If I
else.
go away, Navigator, please
The
bail me out.
penalty.
I know about group coverage.
Okay.
With the penalty, there is, with the Affordable Health Care Act, is there some penalty if, you know, the married couple, they both have different employers, they take, you know, they have to opt in for their own insurances, okay? Is there a penalty if one would have their insurance and also go under the other person's insurance to provide coverage for that deductible?
No, the penalty is only
penalty?
being for entirely uninsured.
Okay, okay, gotcha. Great, thank you very much.
Thank you. Any further questions? Anybody, did I miss anybody?
Susan?
Okay.
I was wondering, does anyone know, are there any changes being proposed to TRICARE coverage? Okay.
Sorry.
Nobody knows.
Jenny has a question.
Had a question?
Yeah. I just got my letter in the mail today. For this year, my premium has been $152 a month. Apparently, it's going up to $400 a month next year. I was expecting an increase, but 166% is,
So I would assume that
and it's not.
the subsidies haven't been updated yet
It's
to
not
reflect. So generally, the insurance companies don't know any of your income information. So when premiums go up for the next year, all they can do is apply the current subsidy that you have in 2017 to your new plan. So essentially, you just need to go back into healthcare.gov or call or meet with a navigator just like you normally would, even if nothing has changed, and push through your information. And that should adjust the subsidy to match how much the premiums have gone up for 2018.
That's the case.
Does that make sense? Because I get calls from those panic letters like every year. And typically, if your income hasn't changed, your premium shouldn't be
Yes.
changing that much. So it really is just a matter of pushing through the information, because the insurer can't get that updated subsidy if you don't go through
Yeah,
the
it does
marketplace.
say that it is only an estimate,
But it sure scares people.
but, you know, why do they bother even mentioning it? It's
Yeah, I think they
scaring us all to
legally
death.
have to send those out, but they just don't really have all the information yet, so.
Good, thank you,
Can I
that's
say something on
soothing.
that too? I've been in the ACA since January 1st, 2014, and at the end of every year, Jenny, we would go back into the marketplace. We would get those letters too, but we always found going back into the marketplace and re-enrolling, the premiums went down.
Yeah.
So that definitely helps.
Good.
Well, thanks for your question. Let's see.
There's a gentleman
Oh,
over here.
Another question.
You didn't get enough attention. I need to pick on you for a second. Is there any chance there's consideration of switching the possibility of going to Ohio for medical benefits rather than just West Virginia?
Well, right now, no. I mean, that's not a chance. I would caution everyone, the talk about opening up state borders, you know, will do a lot. I think we all know, if you read anything about the health statistics in West Virginia as a state, we're not very good. And just because we're opening up, I'm not sure the other states would, the cost doesn't change, you know? So those
Well,
things, I worry about them actually destabilizing the West Virginia insurance markets even further. And we talked a lot about today about what I call cost shifting, which is the providers in our state are dealing often with 3/4 of their revenue being either Medicaid, Medicare, or PEIA, all very low paying. So the commercial rates are high in this state. So it might be a year or two panacea, and the actuaries in the other states are gonna figure it out real quick, and then it'll go back up again. So-
Well, I'm less concerned with state to state as Camden Clark versus Marietta Memorial.
You can, I go to the
Oh,
Cleveland
that-
Clinic
No, with our
on the
policy,
ACA,
yeah.
so you
I
can
mean,
go.
I would be happy if you just accepted Marietta Memorial, even if that's as far as you went, but yeah, I don't care about
Well, the
Ohio
other,
versus
we
West
use,
Virginia.
with Blue Cross Blue Shield, we have, we participate with all the other Blues Plans networks. They're in our network, but what varies is your cost sharing, because we have certain providers in the state that have actually given us a price cut, specifically for ACA. So your deductible may be lower at like a Camden. You might have to pay a little bit more, but if they participate with Anthem in Ohio, they're in our network.
So we're not restricted, is what I'm hearing.
You're not restricted, but you might have to pay more out of your pocket.
Okay,
Correct,
okay.
subject to the deductible maximums and co-insurance amounts. And Sherry, if I go wrong, let me know.
One question, probably for your department. The way her insurance is going to end up, we would have a 5-day non-insured situation. In other words, our insurance runs out November 25th, and we would hate to pay a full month premium for only 5 days. Are there any loopholes where you can only pay for, parts of months or something like that, or is everything strictly monthly?
The marketplace plans always start on the first of the month. They are only available for a full month. So when people have employer coverage or other coverage that ends kind of in the middle of the month, they are in a boat that I don't know how to
So we
bail
can't leave the
out.
house for 5 days.
Now, you should be offered a COBRA plan.
Oh,
from the
yeah.
employer.
Okay.
Sign up for COBRA.
That's a good idea.
Will that cover just the 5 days?
Just to continue what, no, you may have to pay a whole month,
Right.
but you'll, don't go uninsured for 5 days.
But yeah, your
Would be my
market,
free advice to you, which is exactly what
they
they
charge?
paid for.
Thank you.
with loss of coverage, you can do it up until the end of the month, and your coverage will still start on the first of the next day. They waive that 15th as well.
Okay.
You should come on Saturday. Okay.
We covers for 5 days.
I'll throw in a deal. No.
Right
Be there.
Okay, any more questions?
Yep. This is just an easy one. What is the penalty this coming year for not having insurance? Because it's supposed to go up every year, right?
It's staying steady for 2017, and I assume 2018, it's $695 a person or 2.5% of your income, and it's whichever is higher.
Thank you.
What is it for the couple?
Well, it's $695 per person or 2.5% of the income.
Okay, that's a one-time annual penalty, right? It's not like. for
Well,
every
it would
month
be
you go.
prorated if somebody was uninsured for only part of the year, but that's the full year's worth.
Or 5 days.
And for your 5-day, if you do have a lapse, if you're covered one day in a month, you're considered by the government covered for the whole month, so.
Okay.
That's not, you still want insurance for those 5 days.
Yeah.
They won't poke you in the eye for it.
Any more questions? Okay, I want to thank our wonderful panelists. And we can't see you, Catherine, but thank you very much for being here. And I really want to thank Jeff Fox and Chris for helping us, Chris Alfred, for helping us with computer and sound and all that sort of thing. We couldn't have done it without you. So, okay, I guess we're done, and thank you all for coming. Good luck with signing up for the ACA. I think I may have said that enough. Don't forget about Saturday. The ACA Navigators, 10 to 7.